Good morning, everybody. Welcome to Ground Rounds. We have 34 participants, so let's start. I'm very happy to present Placenta Accreta. I am Amanda Roman, one of the maternal fetal specialists at Thomas Jefferson University. Thank you for being here this early with me. This is a fascinating topic. I've been very passionate about it for several years since my fellowship, where I had a great opportunity to participate. They have a great Accreta center, and since then I have been very passionate to participate in the Accreta and protocols. So let's start. The objectives of today are very ambitious. I don't know if I can cover everything. I want to go over definition and classification to determine the risk factors for placenta Accreta spectrum, how to diagnose a placenta Accreta, to share our experience published by our fellow, former fellow, Dr. Johanna Quist-Nelson. And if I cannot cover today, probably I'll do another session to discuss the controversies of surgical management versus conservative management. By definition, then we have placenta Accreta. It's a primary defect of the implantation of the placenta, and there is an abnormal adherence or invasion of the placental trophoblast to the uterine myometrium, and a secondary defect of absence in the normal decidua basalis. So in the cartoon, in the first side, we can see a normal placenta. We see the normal placentation, the endometrium or decidua basalis, and then the myometrium and serosa. In a placenta Accreta, this decidua basalis is lost. And then this is what we will be calling in the ultrasound the myometrium placental interface. So this decidua basalis is lost, and now the placenta is completely in contact with the myometrium. And then there is a continuous invasion of the placenta into the thickness of the myometrium to the point that it will be a full thickness into the serosa and maybe even beyond the serosa. One patient could have all the spectrum from normal to percreta, and not all 100% of the placental surface will be in one spectrum. And so there is, I've seen that when we deliver placenta, sometimes there is a normal implantation in one corner, but then there is an adhesion in the other one. So one patient could have all of them. The FIGO had made a new classification, both macroscopic and histological criteria, and we're going to review this one. So they follow again the normal Accreta, Increta, and percreta protocol, but then the percreta classified in 3 aspects. So the first one is grade 1, or what we call placenta Accreta. So macroscopically, we basically see a normal myometrium. We didn't see any bulging, no placental tissue, no hypervascularity. This is basically a macroscopically normal surface of the placenta. Histologically, well, we try when the placenta is attempted to deliver, and this could happen in a vaginal delivery or in a cesarean section, that massage and attempting gentle pulling of the cord will not produce delivering of the placenta, and then it's required a manual extraction. And during this manual extraction, there is not a good plane between the uterus and the placenta, and therefore it's very difficult to detach it. When finally these specimens go to pathology, either a hysterectomy or a myometrial resection, they identify the extended areas or absent decidua between the villous tissue and myometrium, with placental villi attached directly to the myometrium. So this is grade 1 placenta Accreta, easy to miss, look completely normal when we're doing a routine cesarean section. Then it comes the placenta previa, placenta Increta, or grade 2. In these cases, macroscopically, we find a bluish purple. So I want to point here where the surgeon is pointing at, a bluish purple coloring. Sometimes it looks a little bit bulged. There is a hypervascularity seen here closer to the bladder blade, a dense tangle, bed vessels, and multiple vessels running parallel. And sometimes they can come from the bladder, from a, let's say, an engorgement, parasitic veins, or aberrant veins or arteries. So there is no placental tissue seen invading through the serosa. And if you try to do gentle contraction, the uterus will kind of pull together with the placenta, and it will create the dimple sign. Sometimes you can have situations where you can even have an inversion of the uterus trying to remove this placenta. When we look at the histology, when the specimen is sent, then hysterectomy shows that the placenta villi goes into the muscular fibers and sometimes goes into the lumen of deep uterine vasculars, either radial arteries or arcuate arteries. So this is how it looks like, very hypervascular on the surface of the uterus. These one are actually aberrant veins and arteries coming from the bladder and, let's say, participating in the feeding of this placenta. Then it comes the grade 3 or placenta percreta, FIGO classified in 3 groups, A, B, and C. The grade A is what you see now. It's very prominent. You can see basically the placenta through the serosa, but it's not attached to any other organs. The placenta is bulging, is purple, hypervascular, but there is no invasion into the bladder or bowel or any other organ. The histology shows that there is villus tissue within the breaching of the uterine serosa, but they still can see serosa. The grade 3B, it's supposed to go into the urinary bladder. And then a laparotomy, the villi seems to be invading the bladder, very hypervascularity, very difficult to detach the bladder from the uterus during the surgery. There is no a good surgical plane. And the hysterectomy specimen is showing villi tissue breaching into the uterine, from the uterine serosa into the bladder wall or urothelium. Then the placenta 3C is an invasion into the pelvic organs. Laparotomy, the villi is seen invading the broad ligament, the vaginal wall, the pelvic side wall, or any other pelvic organs with or without the bladder. And in histology, the hysterectomy shows villi tissue going into the uterine serosa, invading pelvic tissues, organs, with or without invasion of the bladder. So this is one of our earliest accretas, where we see this case had a cystotomy because it was very difficult to detach. However, it's not like placenta accreta is like cancer invading other organs and behaving like a metastasis. With the way I see it, and by many years participating in the both diagnostics and surgery portions of the management, is that the placenta previa and accreta creates a very hypervascular situation in the pelvis. And due to the pelvic floor being so well irrigated and had multiple anastomosis to the ovarian artery, round ligament, vaginal arteries, sacral arteries, and all of them connecting inside the uterus, it just creates such a hypervascular state that is very difficult to differentiate what is what. It could invade into the serosa or other organs, or adhesions then became more vascular and therefore more challenging for surgical approach for dissection and let's say skeletalization of the uterus during the hysterectomy. But and many others have presented in lectures that it's not like cancer invading and metastasizing into other organs. Let's review the risk factors and incidence of the placenta accreta spectrum. So the placenta accreta have been increasing and actually quadrupled since the 80s. Initially was a very rare event, 1 in 4,000, 1 in 2,500 cases in the 80s. And it just became more and more frequent. In 2000, the incidence is reporting 1 in 700, and the latest reports are all in 1 in 300 cases. And why is that? It's mostly because cesarean section is the major risk factor for placenta accreta spectrum, and in the association of C-section and placenta previa. And as we increase the number of cesarean deliveries over the years, then we have more placenta previas and more placenta accreta spectrum. This is a seminal paper by Silver in 2006, where they published the association between placenta previa, cesarean section, and accreta. So if we don't have any history of C-section and the patient don't have an accreta, is a very low risk, 0.03. Important to notice that the risk is not zero. It's very low, but not zero. And if you have a placenta previa, then the risk goes up to 3.3%. And you wonder why an nulliparous patient or a patient who don't have a C-section had a placenta previa. And then as we go up with second C-section, third C-section, fourth C-section, you notice that if there is a placenta previa, the risk will go up to 11%, 40%, 60%, and then it's a very high chance that this patient had any form of placenta accreta spectrum from accreta to percreta. These are the latest publication I found with the trends and outcomes of the placenta accreta spectrum. So very important, as I said, the C-section delivery have increased dramatically, and this study included 2.7 million in the study. This is a cesarean delivery registry. It does not include vaginal deliveries. So the incidence, they identified 8,000 women with placenta accreta spectrum, 0.3%. Most of them are accretas, and then a minority, 13% percreta, and close to 10% are increta placentation. During those 2 years, it just struck me like how much the placenta accreta spectrum increases, and increased to 2.1 per trimester. It is because it is really increasing, or increasing our C-section, or just we are increasing our awareness of placenta accreta spectrum, and now we diagnose them more and we take care of them in a better diagnosis and better IDC identification. So if the patient has a history of cesarean section, their risk also increased. If there is no cesarean section, the risk also increases at the same rate. And those with placenta previa are very high risk, 7.8 to 8.7%. So in this group, the rate of placenta accreta spectrum among patients who had C-section were 1 in 370 and increased to 1 in 313. The etiology of placenta previa. So this is a meta-analysis of observational studies, including 58 studies, 30 of them in the United States. And the overall prevalence of the placenta previa was 4 in 1,000 births. And these are the risk factors of having placenta previa: advanced maternal age, multiparity, history of prior cesarean section, anemia, abruption, prior abortion or curettage, smoking, drug use, alcohol use, multiple pregnancies, and some other minor factors. So it is not just the history of a uterine surgery. There are also other risk factors in play that will account for placenta previa. Now, what are other risk factors for placenta accreta? So we have other uterine surgeries, hysteroscopy, myomectomy, DNC, manual removal of the placenta, endometrial ablation, uterine artery embolization, and other miscellaneous ones. So let's review one by one. Having a history of so I wonder, how am I going to evaluate if all of them had C-section? So I found this interesting study of all previparous women in Australia between 2003 to 12. They evaluated almost 1 million of deliveries that were present more than 20 weeks, and they evaluated any other surgical procedures different than a C-section. The incidence of placenta accreta was 22.4 in 10,000, and they account for 38% of all the diagnoses of placenta accreta. 8.7% had at least one procedure, and they excluded all women with Mullerian abnormalities. So these are the characteristics of the patients. Again, older, having placenta previa, and multiple births, and they were associated with earlier gestational age at delivery. The number of procedures that were associated with the placenta Accreta spectrum were, so in gynecology, laparoscopy, all of them included some form of instrumentation of the uterus, hysteroscopy, both diagnostic and operative, curettage, including suction curettage and surgical terminations, any of the above procedures, and then the risk is 2.3. So, and now looking at the number of procedures from 0, 1, 2, 3. So the more procedures a single individual, a single woman has, the risk start increasing from 1.8, 3.7, 7.4 relative risk. It is still on my eye that 82% of women didn't have any surgical procedure. So why these patients end up having a placenta Accreta spectrum with apparently no other surgical procedures, and they account for the majority of the sample. If this is the absolute risk of placenta Accreta spectrum, so no history of procedures is 20 relative risk, and they increases as there are more 1, 2, 3 more procedures, and they adjusted for maternal age or parity, then using no history of procedures as a reference. Every surgical procedure, hysteroscopy, D&E increases the risk of placenta Accreta spectrum. Then is it low-lying placenta a risk factor for placenta Accreta spectrum? So this study evaluated all women that were having a persistent low-lying placenta. They account for 0.4% of all the sample. 34% have a form of prior surgical procedure, and 9.5 of them were encountered with a placenta Accreta spectrum. So about 10% of women who had low-lying placenta, if they have, in this group, only if they have prior uterine surgeries, they were encountered placenta Accreta spectrum. So low-lying is also something to consider. What about uterine artery embolization? So this study includes only women who had uterine artery embolization due to postpartum bleeding. This is a retrospective case control from 2012 to 2017, and they used cases with no bleeding as a control. And all cases were identified, and they had a hysterectomy, and they had pathological diagnosis. So there were 16 women that got pregnant after uterine artery embolization for postpartum bleeding, compared with 3,000 that didn't. There were no differences in preterm birth or small for gestational age, but the incidence of placenta Accreta spectrum were extremely high, 37% versus 1.2, with an odds ratio of 50 times more events. And if you look, they also review literature for other publications. So there's a small series, but all of them goes from 10%, 16%, 23% of risk of placenta Accreta. Now, if the uterine artery embolization is due to fibroids, this retrospective study included 187 women that underwent the procedure. There were 15 spontaneous pregnancies, 2 end up in miscarriage. Most of them had a successful live birth, but there were 2 cases of placenta Accreta accounting for 12.5% of the sample, and they both had hysterectomies. This is another larger sample from the Ontario prospective multi-center trial. 555 women had uterine artery embolization for bleeding, 24 pregnancies, and 18 of them were alive. 4 were preterm deliveries. There were several cases of abnormal placentation, and 2%, 11.11%, were placenta Accretas. So another study that shows a association with uterine artery embolization, either history of postpartum bleeding or fibroids. Now, what about endometrial ablation? The event of having a pregnancy after endometrial ablation is very low, but it could happen. So among 274 women that had the procedure, there were, there were 274 pregnancies in this systematic review. Most of them had termination or miscarriage or an ectopic pregnancy. And among 160 women that had live delivery, There were 36 cases of placenta accreta spectrum with 22% of incidence on the cases that had a live birth. And if you count all pregnancies, there were 14%. So endometrial ablation, they can get pregnant, and if there is a high risk of placenta accreta. After reviewing the risk factors, my home message is we need to suspect placenta accreta for every patient. We need to ask carefully any history of uterine surgeries, DNCs, hysteroscopies, maternal demographics. And we need to know where is the placenta. Are we having a placenta previa or a low lying? And is the low segment clear for a potential cesarean section? Because as we're going to review later, we don't want to touch this placenta in case of delivery. How to diagnose placenta accreta? Now it comes to balance. We want to have a test that will have 100% specificity and sensitivity and telling the delivering doctor, yes, you're going to have an accreta, or no, you're not going to have an accreta. But we still have surprises like, how come did you miss this accreta? Or, oops, you diagnosed accreta. We were very concerned. The patient was terrified the entire pregnancy, and at the end, the placenta delivered. And sometimes we cause more morbidity because we had to do midline skin incision and a classical C-section. So how do we find this balance? We have ultrasound, MRI, and some seromarkers I'm going to discuss. So the most, looking at ultrasound, have been multiple markers that identified as a suspected placenta accreta. So just to evaluate the which marker are best, so we're going to review. The lacunar spaces are one of the most telling signs, and they're trying to grade them into different categories. 0 had no lacunar spaces. Grade 1 had 1 or 2, 1 or 3. There is scattered, there is small. Grade 2 had more lacuna. They tend to be larger, irregular. They're hard to miss. And the grade 3 had many throughout the placenta, and the placenta definitely looks like a Swiss cheese. And the chance of needing a cesarean hysterectomy and maternal complications are positively correlated with the number of lacuna. So the higher the grade, the worse the case. The absence of lacuna in a pregnancy and a placenta previa, it's reassuring of a negative, with a good negative predictive value from 88 to 100%. As I said, these gradings are, here is the association with the placental invasion. So the grade 3 had higher, but higher association. Other findings, loss of retroplacenta clear space. So what's that? So when we're doing ultrasounds, we can see exactly where the placenta ends, and we can draw with a pen where the placenta ends and where the myometrium is, and we can measure the thickness of the myometrium. So in abnormal cases, we don't see that. It's kind of a continuous between the placenta and the serosa, and sometimes we don't see where the placenta ends exactly. Other signs are irregularity in the uterine bladder interface, thinning of the uterine bladder surface. So we can see these irregularities. If we put color, we're going to see the vessels, hypervascular behind the bladder. And there is basically in this figure 4, there is no myometrium. It's the myometrial thickness is almost nothing. So this is case where we can see the bladder. This is bladder look normal in the urothelium and muscularis of the bladder, but then there is no myometrium behind it. The placenta is very hypervascular, and this is a very concerning sign. So which one of them are more telling? So this is some of our patients. It's very important to do transvaginal ultrasound with full bladder. So the bladder will give us a window into the placenta and into the vascular aspects of the bladder and the placenta and the cervix, and it will assist us in diagnosis and planning for the delivery. So they have placenta accreta index, trying to determine which one is more accurate, which one is going to tell us that is truly a placenta accreta spectrum. So the grade 3 lacuna is the most telling, associated with prior placenta previa, number of cesarean deliveries, placenta location, then 2-grade lacuna, bridging of the vessels, and myometrial thickness. So those are the better markers. Now trying to divide it into placenta accreta, increta, or percreta. So placenta lacuna continues to be the best marker, and the more lacuna and the grade 3 lacuna most likely is going to be placenta percreta. And the frequency of these findings in different cases, and the hypervascularity when we use color Doppler to identify, then the subplacenta hypervascularity is very frequent and very concerning. And then the placenta accreta index creates the more parameters we have in a single patient. The probability of the invasion increases closer to 100 with a sensitivity that also is various. It's a little bit frustrating because there is no very high sensitivity or specificity. So if we don't have any signs of the placenta accreta index, then we reassure that the more parameters we have, then we have more chances of having a placenta accreta. This study reviews 23 publications of centers that are accreta centers for diagnosis. And they show a very high sensitivity and specificity and a positive likelihood ratio. But then this is accreta centers with people who do this diagnosis frequently, sonographers, great equipment, MFMs reading, ultrasounds. But if you go to another center who's not trained into the accreta spectrum, then the sensitivity and specificity immediately drops, and therefore you need experience in the diagnosis of placenta accreta spectrum. Then you may think, okay, the ultrasound is not going to give me a good diagnosis, so let's move to another testing. Let's do an MRI so we can be sure. So the diagnosis using MRI have shown that there is no improvement in the diagnosis and management planning for patients with accreta spectrum. MRI may be helpful if the ultrasound is not able to conclude or unable to see the placenta, especially in posterior placentas, when the fetus is shadowing and unable to see very well, so the placenta may be helpful. Again, the MRI of placenta accreta spectrum need to have a placenta accreta protocol. So the slices are very thin and they have special settings for the MRI. There are a lot of imaging that can be interpreted as an accreta spectrum, and they're actually normal. So if the radiologist is not a radiologist who reads accretas and or do pregnancy evaluations frequently, they're not going to be able to read. And they're most likely, what I've seen regularly is they overread the MRI, giving us a very worse prognosis, like invasion into the parametrium, invasion into the abdominal wall. That case into the abdominal wall, when we did the laparotomy, it was an omental adhesion from the adhesion from the anterior, and the uterine wall into the anterior abdominal wall. So it just created that sense of there was a placenta going into the abdominal wall. So these cases are true confirmed placenta accretas, and they just showed here lacuna that we could have identified by ultrasound because of the distance between the skin and the placenta, and images of an accreta. These ones are images of placenta percreta, where there is no more myometrium in this area, and there is lacuna, placenta previa, and there is a concern here for invasion in all this area. That could also be an adhesion, but it's very hard to tell in an MRI, and if the person is not knowledgeable, will be misinterpreting the imaging. So these are all the settings of signs of MRI that need to be encountered. And again, they have a grading system. And again, the sensitivity and specificity is not as close as 100% to we wish. When we compare MRI and the ability to detect invasive placenta, the sensitivity is 94%, specificity 84%. And when we compare MRI versus ultrasound, there is no major differences. So ultrasound continues being the best test to diagnose placenta accreta. Is there any blood marker that we can do and try to detect that there is a placenta accreta spectrum or something wrong going on in the placenta. So they have tried many things. The markers that have been associated, and there are plenty of publications, are the maternal serum alpha-fetoprotein and the PAPA. They have been identified as a markers of the placenta, but they don't tell you what is wrong with the placenta. Even a placenta previa can have abnormal marker, can be associated with placental insufficiency and fetal growth restriction as well. So they're not specific for placenta accreta. They may tell you something's wrong, but they don't tell you what is wrong. There is a lot of research and basic science research going on in placenta accreta spectrum. There is proteomics, there is DNA testing, proteomics, mitochondrial DNA, microRNA. There is a lot of information. The publications are just endless, and still there is no sensitive marker that we can find in the placenta that we can identify in the maternal serum. So the home message for the diagnosis is the best prenatal diagnosis is ultrasound. The best time is late second or early third trimester. See the patient again and again and again. You need to continue mapping. Normally in our unit, we bring the patient every month to do fetal growth. Placenta previa is associated with fetal growth restriction. So it's also important to evaluate for fetal growth restriction. Location. Where is the placenta? The placenta moves as the uterus grows, as the pregnancy advances. So what you see at 28 weeks may not represent what you see at delivery. It's very important that you know where your placenta is located to plan your delivery, how you're going to do the skin incision, how you're going to extract the fetus. You need to know this so you don't get surprises. Do I need an MRI for posterior placentas? So this is my home message for diagnosis. Any questions so far? Okay, so hearing no questions. I don't see anything in the chat. We keep going. So now let's talk about how to manage the placenta accreta spectrum. So it is very important. It's a great difference between identified placenta accreta spectrum versus the unknown that is encountered in the L&D, sometimes in the middle of the night when you're not ready to manage the cases. So this study evaluated that topic, identified versus non-identified. So antenatal diagnosed were 50% of the cases. Patients that were identified before delivery had reduced levels of bleeding with an EVL 50 versus 6 liters. And why is that? It's mostly because you don't know that there is a placenta accreta and you try to deliver the placenta. And in that moment, there is heavy bleeding, you're not ready for a hysterectomy. And by the time you're ready, it's 10 minutes and the patient has bled 5 liters in those 10 minutes. Reduced need of blood transfusion, 59% versus 94%. Also, the requirement of massive transfusion protocols. If you're prepared, you're more likely to have preventive therapies for hemorrhage, either balloons or stents or other team participants ready for a hysterectomy, cell saver, blood in the room. If you know that you have a placenta accreta, it's less likely that you will try to save the uterus to remove that placenta. And if you make no attempt to remove any piece of the placenta and you deliver the baby, close the uterus and start a hysterectomy, then your chances of reducing bleeding and reduce the need of blood transfusion decreases significantly. Sometimes most of patients don't want a hysterectomy. You would like to indulge and try to save the uterus and try to prevent that hysterectomy. But the moment you try to detach the placenta, you need to be ready for heavy bleeding. This is similar studies by the MFMU cohort of 115,000 women and neonates. 100 of them were women with morbidly adherent placenta. Again, this is a 2015, 1 in 700 cases. More of them were nulliparous. 37% had no cesarean section. So remember to be aware of your risk factors, different than C-section. And only half of them were suspected before delivery. So we're always going to miss one placenta Accreta spectrum, either because we never saw the patient, we never scanned the patients ourselves, we did not identify the markers were minor, and we dismissed that solitary lacuna in a place that was not previa, cases with placenta with non-previa that had some signs of concern, but we think that there is no Accreta because there is no previa, and so there is always going to be one of those cases that we don't diagnose. And of course, that they have large blood loss, hysterectomy, and if you're not prepared for the care of the patient, then higher chance to end up in the ICU. So this is the surgical approach that is recommended. The good placenta screening. So always when you're doing any sort of ultrasound, look, where is the placenta? Schedule delivery and have a multidisciplinary team. And you can either go with immediate cesarean hysterectomy or trying to do some uterine conservation, but be ready in case you cannot do it. So this is the placenta checklist in the SMFM publication. You have to have all your identifiers, your team players, and you need to plan your surgery to every single detail. So what do we need? This is the criteria to be a center of excellence of the Accreta Center of Excellence. So you need to have a multidisciplinary team, maternal fetal medicine person to diagnose, obstetrician, experts in ultrasound, expert sonographers, a high grade of ultrasound equipment, pelvic surgeon, in our case, gynecology, oncology, anesthesiologists that know OB anesthesia, urologist in case we encounter a problem or want stents, trauma surgeon, general surgeon, interventional radiologist, and our neonatology team. We need to have intensive care facilities and massive transfusion protocol capabilities, cell saver, and experience into alternative blood products and special blood products. Always remember your risk factors, not just placenta previa and C-section. There are other ones and they can surprise you with the placenta previa. So always think about it, always look for the placenta and see if there is any signs of placenta Accreta spectrum. Remember your sonographic risk factors. Now how to deliver. So if you have high suspicion, these are the cases that you're going to have in a very high index, placenta previa with 3 C-sections, classical C-section, anterior placenta. So any placenta that is on top of a scar is a risk factor. And the other cases that we already reviewed. Before surgery, it is good to have late steroids, and the cases we have done recently when we give the steroids to the patients, more babies are going home with 36 weeks delivery gestation. So it's been rewarding. Admit the day before surgery. You want to be your first case at 7:30, and you don't want the patient to be late, and then everything is delayed. Bypass cross, CVC, coagulation, 2 IV lines, fetal evaluation on a stress test, ultrasound again, things could change, fetal position, and you need to plan your everything in skin incision, fetal extraction, surgical consents, anesthesia, Accreta team, everybody in house and ready to go. Date of surgery and epidural in place. We've been very successful on keeping the patients awake so they can hear their baby and be notified of what is going on with the procedures. And sometimes after that, they get a little bit of sedation, but they still continue breathing on their own. Litotomy position, having an ultrasound for intraoperative mapping to be sure you're not going to do the hysterotomy on top of the placenta, having blood in the room, having the cell saver person, technician, all the surgeons in the room, and the neonatology team and other teams back up if needed. And then you're ready to go. The surgical principles are skin with ample room to deliver a baby and to do a hysterectomy. So depending on where the placenta is located, we have managed to do multiple cases with fan and steel skin incision. And it's also rewarding because the patients are dealing with the loss of the uterus at early age. And on top of that, they're feeling that their bodies are being deformed by a midline skin incision. So some patients can avoid that, and that is been good postpartum. Intrauterine ultrasound, high transverse or fundal. I prefer high transverse round to round. When we stretch the uterus, there is a low chance that the incision will extend into the placenta. The 2 or 3 cases that get classical, because you're stretching and you're struggling with the fetal extraction, end up going down into the low segment with the placental exposure and bleeding. And if you need to do a fundal hysterectomy, then you have basically to open all the way to the xiphoid, and that will be a more morbid surgical procedure, more bleeding and more pain. And then the epidural is not going to help you if you go too high. Then the patient will need general anesthesia. Avoid disruption of the hypervascular placenta. As soon as baby is delivered, we can wait for the 1 minute for clamping and start closing the uterus, and then proceed with the hysterectomy with a stepwise devascularization. Be aware of the suction. I'm the suction person, so I'm very aware of how we're doing with cell saver, and if we need communication to the anesthesia team when it's a blood transfusion needed. And in some cases, interventional radiology. The preoperative preparation with the stents are not placed to decrease the chance of ureteral injury. They are helpful identifying where is the injury, but not to decrease the injury. The pelvic occlusion has shown to decrease some, this is talking about the balloons in the iliac arteries or in the uterine arteries, but they have not been good in Accreta or maybe in Creta. They're very good in Accreta cases. We just use it in our latest case, and I think it decreased the amount of bleeding. But then they have a lot of morbidity. They have side hematoma, thromboembolisms, vascular injury, abscesses, infarction. The patient cannot move, needs to stay completely flat for 12 hours, and that is very difficult to do. This is the cell saver technology. I love it. I'm aware of suctioning. You need to be ready not to suction any amniotic fluid. And then it goes into the equipment with heparinized normal saline, and then goes into the reservoir, had a washout, and then you get RBCs going back to the patients. For about 1 liter of bleeding that you can rescue with a cell saver, you can get a full unit of blood back to the patient. The benefit of vascular occlusion, we have a temporary balloon. In the first case we had, the iliac and the uterine arteries were so large that the balloon couldn't occlude the vessel. So they have to buy a new catheters with larger balloons, so they were able to occlude the iliac artery. So you have to take into the consideration how large the vessels during pregnancy are, that they cannot be occluded sometimes. They are helpful in cases of conservative management, when you want to leave the placenta in situ, and then after the surgery, they go back to the radiology suite for a full uterine artery embolization. The latest reports have shown that it does not really help if you have an experienced surgeon doing a surgical procedure in the fastest way. There is a similar outcome in terms of bleeding. This is our experience. Let's see, we have a question in the chat. TAC is asking if there is a strong association between uterine surgical or manipulative procedure and Accreta spectrum, but all the procedures were done because of gynecological problem. So we don't really know whether Accreta spectrum is caused by the procedure or some uterine pathology. I'm not aware of animal models for placenta Accreta spectrum. There is a lot of studies on histology and, as I said, then biomarkers, proteomics, things like that, but not an animal model. I have not heard of animal models with placenta accreta. Great question about whether like endometriosis or the fibroids itself are associated with the placenta accreta spectrum. I believe they are associated, and especially if you encounter hypervascularity in the abdomen with sometimes spontaneous bleeding. Good question. We have few minutes left. This is our experience with the compliance of the patient safety bundle published by Dr. Chris Nelson. And we just wanted to evaluate our cohort before implementation of our guideline and after implementation of the multidisciplinary approach. So we have 17 patients in the protocol at the time and 22 patients in the post-protocol. The bundle included administration of betamethasone, gynecologic oncology preoperative consultation, and direct involvement, always in the room and ready to go for hysterectomy. So don't pull the placenta if you don't have big brother, Dr. Richard and Dr. Rosenblum next to you. In these cases, preoperative balloon catheters they were using at the time, cell saver, vertical skin incision, or fan and steel, fundal, or high transverse hysterectomy. So the demographics were the same. There were more cases had betamethasone in the post-protocol, and there were more cases that were suspected. More placenta previa, and the patients were, we will start delivering, at the beginning, we start delivering between 32 to 34 weeks, so there is a big difference in gestational age at delivery. There were no differences in regional anesthesia, but you can see we were doing more cases with epidural and with the spinal, and there were, most of the cases were Accreta versus Increta per Creta. The adherence of the protocol, so all components of the bundle implemented, none of the pre-protocol, and 41% in the post-protocol. The number of total of numbers of components, so more components in the, when we were aware of the protocol and the guidelines, more betamethasone, more cases of iliac artery occlusion balloons prior to the delivery. Now we're not using them anymore, as we believe is, if we can do the surgery without touching the placenta. We have had cases with even 500 cc's of EVL, nothing to rescue in the cell saver, nothing to transfuse back. More less verticals. We are doing, we didn't have any fan and steel in this case series, and more and scatter, most of them were fundal and low transverse incisions. In terms of the maternal outcomes, we have slightly less bleeding and less use of products, but there was not significantly different. There were, these are the cases of complications during surgery and intentional cystotomy, but no bowel injury. This is up to 2019. And maternal stay in the hospital from 4 to 5 days. And cases of DVTs, we have 3 pulmonary embolisms. Most of them were readmissions, either here or in another hospital, a UTI, spilo, and there were minor cases. For the neonatal outcome, the major lesson learned when we review our cases in 2019 is we were delivering our babies very early, 32 to 34. And then they were small for gestation, like birth weight was low, and they spent longer time in the NICU. And after this evaluation, we moved our delivery time to 36 weeks. And during these last 3 years, we have not had major events. I remember one patient required delivery at 32, 33 weeks due to severe preeclampsia with HELLP syndrome. That was the day we did 2 cases in the same day. The planned Accreta in the morning, and then when the patient arrived, we follow with the patient who had severe preeclampsia. And another patient had vaginal bleeding and required transportation by helicopter from another hospital, and we did her hysterectomy the next day. Those have been the cases that we have done earlier than 36 weeks. but so far, no complications by waiting to 36 weeks. These are the common comorbidities for the placenta accreta spectrum. There's cystotomies, either intentional or unintentional, ureteral injuries, placenta pulmonary embolism. So especially if you have uterine artery or iliac artery balloons, the patient has to stay flat. They cannot move at all. You cannot give heparin or Lovenox, and then they have more cases of pulmonary embolism or DVTs in other places. Requirements for ICU, ventilation, and infection post procedure. There is another question in the chat. Management of unexpected possible accreta at the time of C-section. I have a slide at the end, but we're running out of time, so I think I'm going to cover the this surgical management, identified versus not identified, and very controversial conservative management for another case. I just wanted to mention that the iliac balloon in our series showed no significant differences in the AVL. They may look like a trend, 1,200 versus 3 liters, but there was no difference, most likely because we have a very small sample size. And I want to finish here and have opportunity for some questions. And I will have another lecture to go over the management. I'm happy to answer any questions from the team.
Dr. Roman, thank you for that review. With the blood shortage that we have now, how exactly do you order, or do you have blood available? How do you manage the high risk need for a transfusion?
Very good question. So initially we had the massive transfusion protocol available, and the blood bank is part of the Accreta team. We prepare, we have meetings before the placenta accretas are coming, and they're very important team players. So the massive transfusion protocol includes about 10 units of RBCs, FFP, cryo, that are moved immediately into the operating room for these cases. As we were having less and less bleeding, they modified the massive transfusion protocol to 4 units and RBCs and 2 units of FFPs, and they have the cryo available, but they don't move it into the room. Now that we have shortage of blood, and they only send 2 units of RBC to start the case, and they have the other ones in the freezer available, and we need a runner, or they can be sent, I think, through the tube. So we have this modified protocol. Also, the cell saver, I love the cell saver, it's great. So if you are just suctioning obsessively, and then you can rescue more blood. And I've noticed that about 1 liter of blood loss, we give you a unit. We use it in some cases that were not accreta, we were suspected accreta. We did the delivery, but the placenta was delivered spontaneously with uterine massage. And I usually request 2 or 3 uterotonics at the time, Pitocin, Metergin, Hemovate, all at the same time to avoid any atony. And still, if the C-section had 1,500, we were able to rescue 1 unit. So I think there is more role. We're exploring, we're reviewing literature and trying to build up a protocol for our labor and delivery cell saver, because it's not only good for placenta accreta, but maybe good for some specific cases in labor and delivery, like placenta previa, or cases that we may suspect are going to bleed more than usual, than any other C-section.
Thank you. It looks like there's a question in the chat from Dr. Martin.
Oh, sorry, I missed that one. And so possible Accreta, yeah, so let me see. I wanted to keep it at the end, but I think it deserves more time of discussion, this one. Oh. This one, what happened if you encounter an unsuspected Accreta? So as I'm showing you in the picture, sometimes you don't know, and you only know when you try to deliver the placenta. So I think one of the things is do not do manual extraction. Always proceed with uterine massage, gentle traction, and uterotonics. And the thing is, it's still very difficult to know which case is going to be an Accreta. Because it's better if you cannot deliver the placenta, do not try a manual extraction, because in that moment you are in no return point, and now you need to proceed with a hysterectomy. If you encounter these abnormal vessels and a bulging placenta through the serosa, and if you don't have a fetal problem, probably better to stop right there and do not do that C-section until you have the team. Monitor the baby, and now you are probably going to wear off your epidural or your spinal, but it's better to call the team before you deliver the baby and open the uterus, because you're going to be in trouble, so you need more help and you need to wait for them to arrive. If you need to deliver the baby, then because of fetal reasons, so avoid touching the placenta. Deliver baby, do not deliver the placenta, close the uterus and wait, or even transport the patient to another center if the patient is hemodynamically stable. As far as you don't remove the placenta and you don't see active bleeding, you should be able to transfer. But I will explore more this unexpected protocol in next session, because we run out of time. There is one more question in the chat. Differences in hysterectomy by race, parity, insurance. Everybody informs of the demographics, but definitely the insurance and the socioeconomical status, definitely in the low socioeconomical status and public or Medicare cases, I have not seen differences in race. Parity, definitely, even in normal vaginal delivery, a G5 had a higher risk of Accreta than a G1 or G2. So definitely these last two are associated with placenta Accreta spectrum. Okay, thank you so much. It's 7:59. I am going to build up another lecture presenting the surgical approach versus the conservative management, because it's very, very interesting coming from the European sides. And I'm going to present this in a second lecture. Thank you so much for your attention and for wonderful questions. And thank you for all your support and help with the Placenta Accreta Center of Excellence.
Thank you.